Welcome everybody to this meeting and an update on the research trial that's planned in Ethiopia. As you join, please could you just make sure you're muted and have your videos off. Thank you, just to help with the bandwidth and the internet connection.
And just as people are joining, I'd also like to say a very quick hello and welcome to everybody. So my name is Michael Carrick. I am an Associate Professor at the London School of Hygiene and Tropical Medicine. I'm Principal Investigator of this study. So big welcome to everybody. I see lots of familiar names. Great to see you all, and really appreciate you taking time to join us either this morning, this afternoon, or whatever your time zone, just to hear a brief update about the project. So I'll hand over in just a minute to my colleague and local senior researcher, Professor Sinowal of Jimma University. But just to re-emphasize that, please do type in introductions into the chat. We sadly haven't got time to go through everybody individually, but hope we can make good use of that. And also just to confirm that we will be recording this session. We'll post it up on the Mammy website. So if you need to drop off later or to share with other colleagues, please do that. So very welcome, everybody. Thank you again for joining. And perhaps over to Sinowal to run through the timetable and plan for this afternoon. Thank you. Sinowal.
Hi, everyone. Thank you, Marco, for inviting me for this part. I also welcome everyone for joining us to this session of updating stakeholders on the progress so far of the clustered randomized clinical trial that's planned that have been ongoing the last almost 1 year. And as we have seen from the logo in the first PowerPoint, we have multiple partners in this. We have London School of Hygiene, Goal, Jimma University, ENN, and Elena Crook Foundation. What you see here is the agenda for the session for today, which will be around two and a half hours. First, we'll have the welcome address. I don't think we need to go through all. I think we will be able to do that. Just from my side, welcome again. I think this is a very nice opportunity for everyone who is interested to learn about this type of work, to get updates, as well as also to see how the collaborative work goes on. This is almost the third time the team has organized a stakeholder meeting. And personally, I'm really excited to see the concept of co-creation or co-development of research in this manner. And we know that the process of starting engaging key stakeholders from the initial point of developing the concept up to the final synthesis of the evidence is of paramount importance for final translation of whatever comes out of evidence. So I think this part is, I would like to emphasize that I think we're doing that part. And I'm sure my colleagues in this session and the coming sessions will be able to share some of the works that have been done so far. Unfortunately, there is some delay from our side because of obvious reasons, COVID. But despite all the challenges, the team has done a great job. Everyone has to be congratulated for that. I welcome you again. I'm sure you'll have a fruitful and a very nice time with the team. So if you have any question or comments, please feel free to write it on the chat box. And if there are questions, our team will be able to respond to specific questions. If there are comments, I think this would be very important for us to take up and improve our work. With this, I would like to stop and invite Mary to take the session. One last note, please, those of you who have not introduced yourself, please write your name and institutions and your interest in Mammy work in the chat box. Thank you. Over to you, Mary.
Thank you, Sinuel. Just checking everybody can see my screen.
Yes, I can see it.
Yes.
Maybe you can put it on full view, Mary.
There we go. Yeah.
Yes, excellent.
Great. Thank you. Okay, so my name is Marie McGrath. I'm one of the technical directors at the Emergency Network, and I'm part of this research partnership that we'll be sharing with you today. I'm going to begin with a brief overview of some of the headlines coming out from 10 years of effort around the management of at-risk mothers and infants under 6 months, or MAMI. What is MAMI, why it's important, where we're heading, how we're building critical evidence in Ethiopia together. What I will share with you today reflects the thinking, dedication and drive of an informal network of researchers, practitioners and experts coordinated by ENN and co-led by ENN and the London School of Hygiene and Tropical Medicine. The MAMI Special Interest Group was formed in 2010 following a 2-year ENN research project that identified critical gaps in policy research and programming. And currently it is an informal network of around 70 researchers, practitioners and experts committed to harmonise efforts, collaboration and to share and learn. So what is MAMI? MAMI focuses on small and nutritionally at-risk infants under 6 months of age. Mothers and infants come as a package. The well-being of an infant is intimately tied with that of his or her mother. Babies that are born small or who are nutritionally at risk, like wasted or stunted, underweight, faltering growth, are at increased risk of death, of later malnutrition, poor development and long-term health outcomes. And there are lots of them. We estimate 8.5 million infants under 6 months of age are wasted in the world. But it's not just infants who are wasted that are at risk. Infants who are underweight, stunted and born small have increased risk of death, poor development and long-term poor outcomes. Helping small and nutritionally at-risk infants under 6 months to grow well is a critical part of the life cycle approach. Making sure mothers are nourished and healthy before, during and beyond pregnancy is essential to safeguarding all our children. Our research and reviews and capture of experiences worldwide found that support in the first 6 months of life was a greatly neglected part of the life cycle approach. Small babies grow into small mothers who have small babies. We need to break this intergenerational cycle of malnutrition. We urgently need to fill the care gap that currently exists for infants up to 6 months of age. We need to act globally. Helping small and nutritionally at-risk infants under 6 months is critical to our achieving sustainable development goals. Our MAMI vision is that every infant under 6 months at every community or health service contact is nutritionally assessed and appropriately supported to survive and thrive. We are actually updating the vision for both the MAMI approach and the MAMI Global Network. And towards the close of this meeting, I will share some of the options we are examining to get your feedback and gut reactions. In MAMI, we want to ensure a continuous pathway of care that identifies, assesses and supports infants who are small and nutritionally at risk. So what does this look like in practice? We have detailed an integrated pathway of care, the MAMI Care Pathway, that works with and within the systems and services and particular needs of mothers and infants. It consists of community screening, outpatient assessment and care, and referral to relevant services. Unlike community-based management of acute malnutrition that originally began, there's not a specific program model to follow. What a pathway of care looks like depends very much on the context. We will test this MAMI pathway of care in the randomized controlled trial in Ethiopia. The MAMI approach is about making stronger links with antenatal services to ensure continuity of care between postnatal care and community follow-up, especially of babies who are born too small. For example, it is about making the most of opportunities when we have contact with mothers, such as during antenatal visits and immunization visits. It is about making the most of every health centre contact a mother and infant has in the first 6 months of life, when they are well, like in growth monitoring programmes, and when they are sick and present to a health post for support. If you take a public health lens, primary prevention prevents disease. Secondary deals with early problems to prevent decline to something more serious, while tertiary interventions prevent serious negative impact on health. The MAMI approach straddles primary and tertiary intervention. On the nutrition front, it dovetails with infant and young child feeding interventions that operate more at the primary level of intervention. So really, it is all about levels of prevention. The MAMI approach is all about building the right relationships between health services, mental health services, social services, nutrition programs, and beyond. From an individual level, between mother and infant, within families and within communities, to service levels and policy levels. We should always look to leverage what exists. The MAMI approach is all about building bridges between infants, mothers and families and societies, communities and community health workers, between weight and functionality, between nutrition and health and disability, national and international bridges, and between development and humanitarian actors and contexts. So where have we got to over 10 years of working together as a MAMI special interest group in the area? Indeed, we've seen good progress. Infants under 6 months are no longer a blind spot like they were back in 2008 when we started. We have seen shifts in policy, with the WHO wasting treatment guidelines updated in 2013, recommending community-based management of wasted infants under 6 months of age for the first time. MAMI programming is being implemented in small-scale NGO-led pilots in several countries, including Ethiopia, and several NGOs have undertaken operational research, including here in Ethiopia, that has really helped inform programming tools development and address further critical research questions. But we are not there yet. Scaled-up care of at-risk infants under 6 months who needs to include community-based management of small and at-risk infants. Community-based management revolutionized the treatment of wasting in children over 6 months, but inpatient care still dominates management of infants under 6 months of age. A review recently completed of 71 national and international guidelines on wasting treatment found only 5 included community-based management for infants. Most, including Ethiopia, still rely all on inpatient care that is more costly for health systems and families, and is often not the best place for the support of these infants. We learned that governments are demanding more robust evidence before they change policy. They very reasonably want to know what interventions work and how in different contexts. How are they integrated within existing systems and services? There may be complex underlying pathology. How do we manage these? What are the implications for cost and capacity? And what is scalable and sustainable? The need to answer these critical questions is what has prompted us to scale up our MAMI special interest group into a MAMI global network. We want to co-create and co-deliver robust, relevant research that is driven by country agendas that informs national and global policy development. We want to do even more together to galvanize and support collective, collaborative, harmonized efforts on research and policy to inform best practice that is scalable and sustainable. We've been part of a MAMI evolution over the last 10 years. We want to bring about a MAMI revolution. And this is why we have turned to you in Ethiopia to lead the way. I'll now hand over to Malcolm and the team to update you on the critical research we are undertaking together in Ethiopia to help fill these national and international evidence gaps. Thank you.
Thank you, Marie, for your nice presentation and finishing it just in time. So now we will be having brief presentations with regard to what we have been doing the last 1 year. We have around 5 presentations. Each presenter will have 10 minutes, and 2 of the presenters are based in Jimma University, and the remaining 3 are presenting from London School of Hygiene and Tropical Medicine. So the first presenter will be Nagga Jibat, who is presenting from Jimma University regarding the qualitative research we have carried out. And second presenter will be Carlos from London School of Hygiene and Tropical Medicine, presenting the quantitative research carried out in Jimma Zone. And the third presenter will be Vasu, again from London School of Hygiene and Tropical Medicine, presenting on the DHS analysis that have been carried out. Fourth presenter will be from Jimma University, presenting on policy guidelines in MAMI in Ethiopia. It's presented by Mubarak Abarra. And the last presenter will be Marco Kerak from London School of Hygiene and Tropical Medicine. He is a project PI, as he has already introduced himself earlier on. He will be presenting on communications and stakeholders mapping. So now the floor is open for the present presenter, Nagga Jibat. You can start, Nagga. Hello, Nagga.
Yes, it is on the slide.
Yeah, you can start.
The voice already recorded. Please open. Who is managing it?
The slides are showing, Nega. Can you see them?
Yeah, I'm looking at it.
Yes, you can start the presentation and just indicate when you want us to move the slides ahead.
So the voice is already on the slide.
No,
open.
you're going to present it live, Nega.
Okay. So thank you. I'm Nagga Jibat from Jimma University. So my presentation will be on carers and health workers' perspectives on malnutrition in infants under 6 months. Please, the next slide, please. This study was conducted in Jimma Zone in the Deder Woreda in Oromia. Comparatively, the two zones are selected based on their nutritional status in terms of food security. So Jimma Zone is considered as food secured area, even if there are some emerging evidences that challenge the decision, because some studies have discovered significant load of malnutrition in the zone. And the other one is Deder Woreda, which is located in the eastern part of Ethiopia. And that is labeled again as, food emergency area. So this study was to inform the RCT mainly. And the study is specifically intended to understand the perceptions of carers on the well-being of infants under 6 months, to explore feeding practices, how malnutrition in infants under 6 months is viewed, detected, and being treated by the community and health workers. Please, the next slide. So this study was purely qualitative, whereby 31 key informant and in-depth interviews were conducted with thematic analysis assisted by Atlas software analysis. Ethically, it was approved by Jimma University IRB, and all ethical considerations were considered. So in this study, mothers and fathers, about 14 of them participated in in-depth interviews, and about 17 health development armies, health extension workers, healthcare workers, and district and zone health office MSH coordinators participated in the study as key informant. Interview totally 21 from Jimma and 10 from Deder participated in this study. So in this study, we attempted to understand how carers define. Please, next slide. On the next slide. Yes, we try to understand how the community, how the people perceive ideal infant. So in this regard, they mainly depend on behavioral manifestations and the physical growth and appearance. Accordingly, they define children who properly and regularly feed and sleep, those who do not persistently cry, children with burping behavior after eating, and those who smile and also engage with people around them are considered as ideal infants. In the same way, they also consider fat and attractive children as healthy and well. In addition, some carers also consider maternal conditions, like whether they have enjoyed care and support during pregnancy, whether the delivery was in institutional setting, and whether the mothers have good feeding behavior and with healthy condition. And finally, whether ANC, PNC, exclusive breastfeeding and vaccination are available for the children. The next slide. So with the results, we tried to see how they consider their feeding practice among carers. Accordingly, health workers promote exclusive breastfeeding as the only and the most desired feeding practice for this age group, unless there are some exceptional reasons. All health workers also have similar awareness about the practice and with strong values, and they also put effort to make it reality. Coming to the carers, they have good awareness about exclusive breastfeeding, and most of them also have positive perception about exclusive breastfeeding, yet there are some who challenge the practice from cultural point of view and from their living conditions. So we could understood that there is uneven practice, including among health extension workers when they act as parents. So we came to know that everybody knows about this exclusive breastfeeding, but not everybody practices. When it comes to additional feedings, which is introduced as early as of the first day with some degree of exaggeration, yet not to undermine all the effort is there, but these are the cases in some mothers. And even those who claim practicing exclusive breastfeeding don't do that to the full range of 6 months. So there are some challenges with regard to practicing exclusive breastfeeding, which are related with living conditions, mainly the work nature of the mothers, which is very bold in the Deder area. There are also social views and pressures related to consultations with elders and the neighbors that challenge. And also employed mothers complain shorter maternity leave, which discourages them to practice exclusive breastfeeding to the full range of 6 months. So locally available food items are introduced mainly, and formula feeding is emerging in some sections of the society. Next slide. As part of this, we also consider maternal and health feeding practice, which is integral part of under 6 infants malnutrition, whereby we came to know that there is increasing awareness and the concern among health workers about less attention given to the mothers in this regard, whereas carers by themselves are well informed about this issue, but they are less seriously taking the issue compared to exclusive breastfeeding. Health workers also advise mothers to have variety and at least one more meal per day. But coming to carers, we came to know that they are reluctant due to cultural and economic reasons. Culturally, it is not acceptable for mothers, for wives to have different food from their husbands, which is not appreciated. And again, there are also some food restrictions during pregnancy. Many families are not in a position to afford those recommended food items to have for their wives. Health extension workers demonstrate how to prepare balanced diets in the community, in the village, whereas mothers usually sell those recommended items so as to purchase cheaper food items like biscuits for the family. So there is a witness from health workers that poor mothers have health conditions and they are worried about that physically, socially, and mentally. Socially, women or mothers complain that there is persistent dispute, marital dispute, and at least they have less cooperation from their husband. They said mentally, many women have stress features. And again, mothers with under 6 malnourished infants are also malnourished themselves. Again, this is particularly bold in the eastern part in Deder area. Next slide. With again, failure to meet the expected behavioral and physical manifestations that we have seen earlier. These are considered as general indicator of infants as health problems, and mainly thinness, persistent crying, edema, and unable to suck are well considered as the most indicator for carers. In principle, health workers are expected to more rely on standard measurements than physical indicators, yet we identified that there are some gaps in using the measurements and at least for, in some cases, to skip the procedures. So potentially in the future, MIWAC is preferred and easier to use for under 6 infants as reported by health workers, yet they have some reservations, some fear about this diagnostic power compared to the other measurements. Continue with the next. Coming to the treatment, the standard treatment is given at health centers and hospitals, whereby health extension workers screen and give counseling service for mothers. And the other role for health extension worker is referring the case to health centers. Carers' care-seeking behavior for under 6 infants has improved. For example, there is positive response to referral order unless they are economically constrained. Currently, most carers prefer visiting health center, bypassing the health posts because they know that there is no treatment for this age group at health posts by health extension workers. Yet the community aspire to get the service at the nearest possible at health post or even at home. We also came to know that there are several treatment challenges related with carers. For example, mothers are not willing to stay in the health facilities when their infants are admitted, and in some cases even they have escaped from the hospital or from health centers, leaving their infants in the health facility. And there is also difficulty of having stopping additional feeding that they have already started, and which is also considered as part of the causes for the malnutrition. With health workers, there are some low commitments with some of the health workers, and also there is inadequate training for the newly employed health workers so as to provide the service. With supplies, there are many complaints from the health center in particular, lacking essential materials to give the service, and the COVID by itself has also emerged with its own challenges of the treatment. The next and the last, please. With the conclusions, we can say that there is growing and shared understanding between carers and health workers on matters of infant health. However, improvements, including in exclusive breastfeeding and others related to this one, are still accompanied by persistent challenges. Delayed interventions, less attention, and limited success are observed in improving maternal conditions, which is very closely related to the issue we are dealing with, which have multifaceted negative implications on the infants, on the mothers, their family, and the community at large. Therefore, policymakers, implementers, and the users, including the community, should collaborate and actively engage in reducing the risk. In doing this one, involvement of men, given their influential decision on the lives of their wives and their family is very important to be considered. Thank you very much.
Thank you, Naga, for informative presentation. Now, Carlos will continue. While Carlos is presenting, Naga, if there is any comment or question forwarded to you, you can respond in the chat box, or probably you can prepare a response and you will respond finally. So, Carlos, you have 10 minutes as well.
Thank you very much, Melkamu. Hi, everyone. Thank you very much, everyone, for being here. My name is Carlos Grijalva. I'm a researcher at the London School of Hygiene and Tropical Medicine, and I'm part of this amazing MAMI team. So what I'm going to be presenting to you now are the preliminary results of our health center survey. I just wanted to kind of first place it within the context of what we're trying to do. Our main task as a group is to undertake a large-scale RCT testing the community care pathway. But to do that, we need to undertake a lot of formative and early research to be able to fully understand the local setting. And part of this is this health center survey. Also, we're going to be hearing from Basundra about secondary data analysis she has done with the DHS. I'm going to be touching briefly on the health center assessment, and Nega has kindly presented to us the really wealth of information of this qualitative study. So all of that ultimately was entered into the cluster randomized control file that we are finalizing its design. So without ado, I'm going to go straight into the center survey. What we have, oops, for some reason it's not changing. Yeah. The main objectives of this survey was primarily to assess anthropometric deficit prevalence in infants that are attending the clinics in Jimma and in Deder. To assess also how much anthropometric deficit overlap exists and how this could give us some understanding of the utility of potentially of using MUAC or weight for age set score for assessing the risk of being, well, basically to identify being small in this particular age group. As Nega very nicely presented, there is the interest by the health workers to try to use more simplified approaches. Also, we wanted to assess some of the infant feeding practice at this stage. Our primary focus is on breastfeeding. So I'm gonna be just touching upon all of this in turn. So you can see in this map, this is just briefly for those of you who are not familiar with Ethiopia. This is Ethiopia divided by the different Weredas in areas and zones. So here you can see in green, the Jimma Zone with where are we collecting. This is the larger area where we are collecting information, where all the health center clinics are scattered in this region. And then in orange, we have the Deder Woreda, where we are also collecting information of all the health centers. For reasons that I don't understand, my computer is just moving forward without me. So apologies if I'm going backwards and forward. So what we have done so far, we did first a health center assessment to be able to undertake this survey. So we visited 71 health centers, 63 in Jimma and 8 in Deder. And we ranked this according to distance, ease of access, and patient load. And based on these three characteristics, we selected a subsample of health centers that were within an adequate distance for undertaking the RCT, that were sufficiently ease of access and they had sufficient patient load. And we collected, and we, randomly selected 10 of these in Jimma and 8 in Deder. And we started collecting data in each of the centers. Originally, we planned to do it a 3-week period data collection, but we ended up just running a 2-week period. So we have so far done all the collection in Jimma. This finished on November the 26th. We managed to survey 625 infants under the age of 6 months. But we are currently undergoing this in Deder. I'm happy to say that we just finished last Friday the pilot, and today we started collecting the data. So all the results I'll be presenting are just coming from Jimma. And what you have in front of you is a histogram with a distribution of all the ages of the children that attended the clinics these 10 clinics in Jimma. Now you can see some interesting patterns. First, you see a paucity of children that are between the ages of 1 to 6 months. Now this is kind of like the profile of infants that are attending the clinic. Children seems to come more often to the clinic to start their vaccination, ideally at the age of 6 weeks, but really they are starting to come at the age of 7 to 8 weeks. So there is some gap in a way of children. Well, not gap, but there is just not sufficient or large enough sample attending the clinic that are between the ages of 1 to 6 months. So this is something to keep in mind as a limitation. So this is, broadly speaking, what we are looking at the anthropometric failure overlap. This is a way of presenting data that is called the composite index of anthropometric failure. Here we are just looking at 3 particular categories: stunted, wasted, and underweight. And we are trying to see how these overlap. Now, in the table form, it's a little bit tricky to understand. So I'm going to be using Venn diagrams to present you this in more detail. But suffice to say that what we're looking in here is that by thinking just of wasted, stunted, and underweight, about 16.5% of the children attending the clinics would present some form of anthropometric failure. So let me just start with a Venn diagram. I'm going to start presenting you a set of ovals and giving you some of the information that I have in here. So from the set of oval, you hear here the prevalence of stunted. The prevalence of stunted we had 625 children, but I'm presenting data of 614 children with all the complete data. We have 11 children with infants who couldn't complete all of the data. So, I mean, it's 98% of the data, so it's good enough. Of that 614, 7.5% are stunted, whereas 8.1 are wasted. Now, interestingly, I mean, it doesn't look quite high, but it's more or less what we would expect around the value of around 10%. Now, when we start looking at underweight, we have slightly higher prevalence. Of those 614, 70 children were underweight. This is, again, weight for age set score below the -2 set score. So it's about 11.4%. And when we are looking at low MUAC, we got 87 children with a value of low MUAC. And here we're building upon very interesting work that GOAL has been doing in Ethiopia, where they are kind of like testing a particular cutoff value of 11 centimeters. So here we are defining low MUAC as less than 11 centimeters, because obviously at present, no official definition exists for low MUAC in infants under the age of 6. So if we take that definition, we have about 14.2% of the infants under 6 attending clinics with these characteristics. So my computer is rushing me. So here we are starting to look at the overlap about stunting and wasted. One of the things that you see is that already at this age, there is some overlap. So there are children that are concomitantly stunted and concomitantly wasted, although this proportion is not that great. It's about like 10% of the children who are either wasted or stunted would be concomitantly wasted and stunted. Now, when we look at the overlap between underweight with wasted and stunted, we start seeing a few interesting patterns. First, about like 60% of the children who are stunted or wasted would be picked up if we were to just use a more simplified value like underweight, but we will be missing about a third. Now, at the same time, we will be adding some few children who were not either identified as stunted or wasted, but they are being identified as underweight. Now, together, as mentioned before, this counts underweight, stunted, or wasted about 16% of the children. Now, it's interesting to contrast this with the value of low MUAC as -11. Now, I just want to do it again so that you can see this shift. And please pay attention to these particular numbers, which are the children who are not being picked up by underweight that are wasted or stunted. What we're seeing is that a greater number of children who are wasted or stunted would not have been identified if we were to be using a low MUAC kind of indicator. Now, interestingly, we are getting a large proportion of children who would be considered, well, who are presenting low MUAC, who would neither be stunted or wasted. So if we were to use low MUAC, stunted or wasted as a definition of anthropometric deficit, we will be having about 22.5% of the children. Now to complete the flower or to complete this Venn diagram, we have the underweight, low MUAC, stunted, and wasted. Now, interestingly here, few patterns emerge. First, if you look at the underweight and low MUAC overlap, the overlap is about 1/3 of children. So the overlap between these two indicators are not very strong. Two, that there is a very few children who are either wasted or stunted that will be picked up by low MUAC that are not already being identified by a weight for age. And yet we still have a large proportion of children who would be low MUAC, who would be neither underweight, stunted, or wasted. Now, if we were to use all these four indicators, about 24% of the children would be considered to have anthropometric failure. That is about 1 in 4 infants in this attending the clinics. Now, one interesting pattern we found is that age seems to have an impact on this kind of overlapping relation. So apologies if this library is more complicated, but what I have done is I have taken the sample and I have split it in two, using as the cutoff the first 2 months of life and the third, fourth, and fifth month of life. So the first 10 weeks and 11 to 25. And there is a couple of interesting patterns that emerge. So on your left-hand side, you have the younger ones, and on your right-hand side, you have the less young ones, or a little bit older ones. First, those 45 low MUAC that are neither underweight, stunted, or wasted, they cluster in the young. You don't see those in the old. Now, interestingly as well, the overlap between, so the children that are identified as stunted or wasted that are not being picked up by underweight, these are almost inexistent in the older children, but they tend to kind of happen more around the young. So there seems to be that low MUAC might be more tricky to use as an identifier for severe, but for anthropometric deficit at a younger age. Seems to identify a lot more that are not underweight, nor stunted, not wasted. This does not seem to be the case for older children. However, underweight seems to have seems to be better at kind of like at identifying those who are stunted or wasted. And it captures those also who are low MUAC at this age. So I'm going to stop here with the anthropometric data. You can start seeing some of the patterns. The patterns are a little bit complicated. Now, one interesting thing also to think is that, sorry, just in this one, going back, that when we're using a low MUAC value, we are capturing about 80% of those who are concomitantly wasted and stunted, whereas with underweight, we seem to capture all 100% of them. And with this, I move now into breastfeeding. And I want to show you this image. This breastfeeding image, what we are here seeing is let's say, the disappearance of exclusive breastfeeding. We're plotting it here by age. We're seeing that at a very young age, about 80% of the children are being exclusively breastfed, and this practice seems to drop very quickly. So by about 8.7 weeks of life, half of the children would no longer, half of the infants, sorry, would no longer be breastfed. That is very young. That means that exclusive breastfeeding, by 2 months, half of the children are no longer exclusively breastfed. So we look at the introduction of different liquids. So here I'm showing you another graph. You have the red dotted line is the introduction of water. You see when it starts emerging in the diet. You have the green, the milk. You have this blue, which is other liquids, and you have also the bottle feeding. You can see that the main culprit appears in our sample to be water. Water seems to be entering into the children's lives quite early on. And by about 11 weeks, so about 2.5 months, 50% of the infants in our sample are already receiving water. So, I mean, we are here identifying an interesting point of intervention. I mean, milk is about 23 weeks. About 50% of the children are already receiving some milk. So this is almost at the end of the 5th month. Bottle feeding is way beyond the 6 months when you will have a lot of bottle feeding. So bottle feeding doesn't, I mean, it's not small, but it does not appear to be quite large in this particular population. So just to conclude, anthropometric deficit ranges between 16 to 22% according to the type of indicators or collection of indicators that you are using. There is a great overlap of this, but weight for age set score of -2 seems to overlap better with the indicators of stunted and wasted than low MUAC. Exclusive breastfeeding in this population is low and it falls very rapidly with age. So there is a lot of work that perhaps needs to be done for this in this setting. And water provision appears to be an important target for information. And with this, I will stop. Thank you very much. And I hope I managed to stick to the time.
Thank you, Carlos, for your nice presentation. You have few comments in the chat box. You can respond to them in the meantime, while other questions and comments are coming. Now, the third presenter will continue, which will be Vasu. She will be presenting on DHS analysis. So the floor is for you, Vasu.
Can you hear me? Hello everyone, my name is Vasantara. I'm a recent graduate from London School of Hygiene and Tropical Medicine. I'll be presenting the research project that I undertook as part of my MSc under the supervision of Dr. Marco. The title of my research project is Weight for Age versus Weight for Length in Identifying At-Risk Infants under 6 months in Ethiopia, using secondary analysis of demographic and health surveys. The study aimed to inform the current policy debate around identifying better anthropometric indicator, weight for length, Z-scores, and weight for age, Z-scores, to identify at-risk infants under 6 months and to improve the initial part of the Mammy care pathway, and also to generate evidence to contribute in designing of the upcoming cluster RCT in Ethiopia. The specific objectives of the study were, first, to explore the data quality of anthropometric measurements in DHS. Second, to estimate the prevalence of wasting, underweight, and stunting, and the changes. Can you hear me? Sorry, I'm getting some messages.
Yes, we are hearing you. Yeah, we are hearing you. You can go.
Okay, sorry. The third objective was to explore the strength of associations between the established biologically plausible risk factors of undernutrition with WLZ scores and WAZ scores. Coming to method, the methodology included secondary data analysis of children record files from DHS 2000, 2005, 2011, and 2016. All infants under the age of 6 months and their mothers were included in the study. The complex design of the survey was accounted in the analysis. To meet our objectives, I looked at the missing data, extreme values, and flagged anthropometric indices to explore quality of the measurements. Prevalence of wasting, stunting, and underweight were estimated after excluding flagged data based on WHO cutoffs. Lastly, bivariable and multivariable logistic regression models were used to explore the association between the established plausible risk factors related to infants, mothers, household with wasting and underweight. Moving to the results, the length measurements had greater missing values as compared to the weight measurements. Length-based anthropometric indicators had more flag data than WAZ scores, with an exception in DHS 2005, where WAZ flags were slightly higher than WLZ scores. Overall, this indicates that even in well-conducted surveys, length-based measurements are of lower quality. This slide shows the prevalence of undernutrition in infants under 6 months. Between 2000 and 2016, the prevalence of stunting, underweight, and wasting declined. On comparing the last two surveys, that is 2011 and 2016, an increase in the prevalence of wasting, underweight, and stunting was noted, albeit the changes were insignificant. In all 4 surveys, the prevalence of infants with concurrent wasting and stunting was less than 1%, and all WAST infants were underweight. The upcoming slides present association between risk factors and WLZ and WAZ scores. The multivariable analysis showed that there were no effect of age, sex, and birth order on wasting and underweight. There was a clear gradient of association and plausible trend between birth size and WAZ scores. In terms of feeding, current breastfeeding and still breastfeeding was significantly associated with reduced odds of underweight. On the other hand, never breastfed infants were at the higher risk of being wasted and underweight. However, it was not statistically significant. Bottle feeding had surprising direction of association, but it was non-significant. Furthermore, fever and cough in the last 2 weeks had strong and plausible association with underweight. If you see the odds ratio noted for illness was stronger for underweight than wasting. For maternal characteristics, maternal BMI over 25 showed strong and significant protective effect on underweight. Maternal height over 145 centimeters had plausible association with both wasting and underweight. However, it was not significant. There were 2 interesting findings that we noted in the study. Infants had higher odds of being wasted and underweight whose mothers had higher education. And secondly, marital union had opposite direction of effect on wasting and underweight. Union appeared to be a risk factor for wasting in the infants. Likewise, type of residence had opposite direction of effect on wasting and underweight. However, it was non-significant. Father's primary education had opposite direction of effect on wasting and, father's primary education was significantly associated with underweight. In this presentation, I showed findings from only from DHS 2016, as they are more recent and relevant to the planning of cluster RCT in Ethiopia, but all 4 surveys showed more and stronger association between risk factors and underweight, that is WAZ. To conclude, length-based anthropometric indicators are problematic as length measurements were more prone to missing values, outliers, hence producing less reliable WLZ scores. Another disadvantage is that WLZ scores can't be calculated for infants with length less than 45 centimeters due to the absence of growth standards. Lastly, WLZ scores are less strongly associated with known possible risk factors. On the other hand, WAZ is more reliable, practical to use in the field, and clinically better as it associates strongly with the risk factors. Second key message is that infant anthropometric deficit is complex and multifactorial. Anthropometric deficit is not just a diagnostic tool, but also a symptom to identify underlying problems. Hence, the management package must be comprehensive, including focusing more on family and social involvement and not just limited to breastfeeding and counseling. Thank you so much.
Thank you, Vasu, for your nice presentation again. So now the turn is for Mubarak Abarra, who will be presenting on policy guidelines and MAMI in Ethiopia. You can start, Mubarak.
Thank you, Malcolm. Are you able to see my screen?
Yes.
Thank you.
Merge it, make it in a slideshow form.
Okay. Thank you very much, everyone. I will have a brief presentation on research, policy, and guidelines. I will only take a couple of minutes to finish my slide. So as we are doing research to support the health and well-being of the community, we have to ensure that there is a clear link between policy, guideline, and research findings. So I have tried to find out some available policies and guidelines in Ethiopia that are in line with our research project. I have found out some policies and guidelines in Ethiopia and in line with the nutrition program for young infant and children. So in 2019, we do have the new national guideline for management of acute malnutrition. Also, we do have a new national OTP guideline developed in 2019. And we do have also the national nutrition programs that have served between 2013 and 16. We have revised it just this year, not yet approved, I think so. We do have also adolescent, maternal, infant, and young child nutrition guideline, which is in work now. And we do have also national strategy for newborn and child survivors. All are currently in place to work by the Ministry of Health in Ethiopia. The National Nutrition Guideline have a clear focus on early breast feeding initiation and exclusive breastfeeding for young infant and newborn, feeding during difficult circumstances, and also how to feed infant in the context of HIV/AIDS infection, and how to feed the young infant during emergency conditions, and also how to feed infant for low birth weight or small to their age. So these are the strengths of this nutrition guideline, emphasizing how to breastfeed during the context of difficult circumstances. However, the gap in this national guideline is that there is less emphasis for young infants less than 6 months of age, and there is a clear evidence gap on how to feed and manage this young infant in the context of these difficult circumstances. However, we do have also mental health policies and guidelines. The National Mental Health Strategy of Ethiopia first has been developed in 2013, and it is revised in 2020. It has a clear emphasis for maternal and child mental health and well-being, and it has also a clear focus on how to help and improve the health and nutrition and development of infant. The gap in this national mental health strategy of Ethiopia is that it needs a culturally relevant approach on how to effectively integrate the mental health service with the nutrition of a young infant and also the mother. So there is no clear link between the mental health service and the nutrition service for a young infant and the carer. There is also early child care and development policies and strategic documents. These are revised in 2020 and will serve until 2025. These policies and guidelines have a clear emphasis for adequate care, nutrition of fetus during pregnancy, and this policy and strategic plan gives emphasis for the nutrition in the first 6 months of life, stimulation since pregnancy throughout early life, safety and security, maternal well-being, responsive care since birth throughout childhood. However, there is a clear gap how to effectively integrate these early childhood development programs with the nutrition, stimulation, the mental health service in the healthcare system. While we do have a clear policies and guidelines developed in the country, in the healthcare system, they all emphasis for older children and infants. There is a gap for young infant. Whenever there is emphasis for young infants, there is lack of evidence and effective way of delivering care and service for this specific population. So I'm hopeful that the current research finding will serve to fill the gap in the country. Thank you so much.
Thank you, Mubarak, for your nice presentation. And last presenter for this session will be Marco Kerak, who will be speaking on communications and stakeholders mapping. You can start, Marco.
Thank you very much. Again, big thank you to all for joining. So just a few slides and we'll open up to questions, and I see that lots are coming in on the chat. So very much valued. And again, big thanks from me to all the presenters. So I'll just talk a short while about the stakeholder analysis and communications. And biggest thank you here to Rosie Kauper from the SDG2 Alliance, who's been really leading and supporting us with this work. So the aim of this sub-project is to maximize the value and impact of the MAMI project by understanding the needs and perspective of our key stakeholders. So what we want to do really is to map who the key stakeholders are, to develop a strategy to inform and engage with the stakeholders, and by way of an initial objective, to identify key communication materials relevant to MAMI and in current use in Ethiopia. So what we use this stakeholder matrix where we divide our stakeholders using a grid into those with high power versus lower power and higher interest versus lower interest. And it's really key just to emphasize that everybody is important, but it's not going to be of such direct impact and interest to everybody. So power refers to the ability to influence the structure and activities of the program, whereas interest is how directly relevant it is to them. Now, for example, things like malaria is hugely important and is definitely of interest to us, but it's not our key interest. So for us, that would be low interest. And so what this matrix does, it divides stakeholders up roughly into 4 sections. And if for those who are high interest and high power, it's important to engage with managing. For those who have high interest but lower power, for example, our patients and the community workers who are really, really important, it's key to keep them informed. For those who may have higher power, but perhaps have MAMI as one of many projects, important to keep them, again, updated, keep them satisfied with information, and for the others, monitored. So it's about the right amount of information to the various stakeholders and making sure that those who really need to know, whose core interest this is, are adequately updated, but also that we're not flooding inboxes and not keeping others too overloaded with our communication materials. So just an example of how we're doing this. So we're dividing them up into local levels. So within country, ranging from Woreda, for example, the communities, local leaders, health development army, community healthcare workers, etc. Then there are zonal stakeholders like zonal health officers. There are regional stakeholders. For example, Jimma University is regional, but also acts at national level, has national significance, regional health officers. And then many national, federal level. And again, big thank you to those from Ministry of Health. And I see lots of senior people online today and really appreciate your taking time to join us. So lots of key stakeholders at national, federal level. And last but not least, lots of key international stakeholders, for example, UN bodies, NGOs, and donors. And big thanks especially to Eleanor Crook Foundation, who are supporting this work. And I see Chaitanya's just joined us at what must be a very, very early hour in the States. So thank you very much to Tanya and everybody at Eleanor Crook. And so what Rosie's done is she's mapped the stakeholders. And again, just to emphasize that everybody's important, this grid is just to help us how to target our communications, how to target our strategies, and how to differentiate who needs to be more closely involved and informed versus who can be more loosely informed. And one thing that we've certainly noted is that this differs in the short term versus the long term. So the kind of organizations, individuals that are key to research are different to project. And then finally, just a big thank you to all who shared communications materials. And this is a sub-project that we did with the view to synergy rather than competition. So rather than reinvent messages, posters, other communication materials, etc., we reached out to a number of different organizations to share what they've already done. And we see this as a good example of a win-win stakeholder engagement. So it's a win for the organizations who are sharing, because their messages, their materials, which they've worked really hard to develop, invested lots of resources to develop, get wider dissemination, and therefore we hope wider impact. But it's also a win for the immediate work that we're doing, because we don't need to start from scratch. We're using tried and tested materials, and again, we're increasing impact. So a big thank you to you all for joining. And we very much value your time and inputs and questions. And with that, I'll open to questions and back to Malcolm. Thank you.
Thank you, Marco, and all of the participants of this meeting. I think we have a dedicated time for questions and answers, probably later on. So I just give the chance for Maurice so that she can pass some messages. And while we are entertaining the questions and comments that are put in the chat box for the moment, let us hold our questions for the later session. After probably an hour, we will have a separate question and answer session. So we will discuss more during that time if there are any remaining issues. For now, I think it's good if we just continue with subsequent sessions, as we are not having any additional time. So Marie, you can take the floor now for subsequent actions. Thank you.
Thank you very much, Malcolm. And I just wanted we thought it'd be very nice if everyone could pop their videos on for a minute or so, and we'd try and take a snapshot of you all attending. We would love to have been in person like we did about a year or so ago. We gathered together for the opening stakeholder meetings in Deder, in Addis, and in Jimma. So as we can't be physically together, we're connected virtually. Perhaps if everyone could just turn on their videos, and we will just try and have a little snapshot and see each other for a few moments.
So this is the modern equivalent, the Zoom equivalent of our group photo. So sadly, we're very much missing Ethiopia. So we had, certainly for me, that was one of the best trips and I've ever done work-wise last year. And now there's light on the horizon. Very much hope that in 2021, that they'll be, that we'll be there in country again, so that the next meeting will be in person. So Marie, over to you.
Great, thank you. So, and please don't feel under pressure to turn on your screen. We're all working from our home. So we've all seen inside our bedrooms and our offices and our sitting rooms and dining rooms. So please, you're amongst friends when you're with the Mammy group, so don't be shy. But equally, if you can't share your video, we won't take it personally either. I'll just give you another few seconds. A few people who haven't yet shared, but perhaps Annabelle, maybe you could start taking some little screenshots.
Don't worry, I'll take some now.
Carlos is fixing his hair.
Yeah, make sure to add some hair in the bald patch area.
The Photoshop touch-ups are for free. We'll do that as part of the Mammy service. So any additions that people would like. So Carlos,
Yes.
more beard, hair, we can...
The little wrinkles on the side of my eyes.
Can happily do.
How are you getting on, Annabelle?
I've got a few, so hopefully we've got a good one in there somewhere. Thanks, Marie.
Fantastic, thank you. And then we've scheduled a little break, and we're just taking, and we can add a little bit of time to the discussion afterwards. We'll have a good discussion session, we hope, in the afternoon. And when we return, Marco will share some details on the randomized trial, and then we'll go into a discussion section. But for now, we're going to take a little break. Please don't log off. And what we're going to do is we're going to just randomly assign you all into little breakout rooms so that you can come back, go grab your coffee. And we're very jealous of you all in Ethiopia with your very nice coffee that you'll have there. And maybe just come back and just have a little chat and meet each other in this little breakout room. And then we'll automatically bring everybody back to the plenary session.
Brilliant, thanks.
At 1:30.
Yeah, so what we're trying to do, we're trying to recreate the coffee queue. So if we take maybe 5 minutes for a comfort break to go and grab your coffee. So I'm just on the last little bits of the Ethiopian coffee I bought back last year. But then we'll go, join the breakout room. So the equivalent of the coffee queue. And then we'll see you in 15 minutes. And I'll go through some RCT plans. So thank you all very much.
See you soon.
Thanks all very much. I hope everybody's had a chance to get a coffee. Yeah, hopefully as much Ethiopian coffee as possible. So I've got a little bit left. Yeah, we'll just give people a few more seconds to dial back. I think some people may have had to leave, but can everybody see my screen at the moment? Tanya Mubarak?
Yes.
Yes.
Yes, sure. Yes. The main thing is we really value everybody taking time to join, because we'd love to hear from you, your reactions to our preliminary findings to this formative research, and also some thoughts on the planned trial. So we're hoping to submit to ethics very soon, so shaped by this formative research. And what we'd like to do is just share a few slides on our plans at the moment on the outline of the trial. And then we're going to have about half an hour just to discuss as a group comments, feedback, ideas that you may have for improving and adjusting the trial. So it's about the management of small and nutritionally at-risk infants under 6 months. So the overall aim is to generate and disseminate quality evidence that outpatient care using a Mammy care pathway is effective, safe, and cost-effective, with potential for scale-up. And again, big thanks to all our partners, and it's a particular pleasure to be working with Jimma University, whose mission statement, whose motto, "We are in the community," I think really resonates with our focus, our interest to engage at community level. So our primary question is, does outpatient care using the Mammy care pathway improve the growth, health, and development of small and nutritionally at-risk infants under 6 months? We've got a number of related secondary questions. So a big one is not just the effect on the infant, but the effect on maternal health, so especially maternal mental health and well-being. We have a whole package of work led by Kidus and colleagues in Denmark, where we hope he's going to be registering for a PhD very soon, on health economics, looking at the cost and the cost effectiveness, both from the health system perspective and societal family perspective. And Marie and ENN colleagues are leading on a process evaluation. So what can we learn from the RCT? And we've also just heard that, again, together with the same team, but being joined by colleagues in Jamaica and Malawi, we're also looking at non-communicable disease risk, and we'll be taking bloods to look at biomarkers for NCD. So our basic study design is a cluster randomized trial. So we've got health centers which will match, and what we'll do, we'll randomize them into pairs. So we'll match health centers into pairs, and then one of them will randomly get allocated to control, which is the red, and intervention, which is the green. So we'll do that. So again, in pairs, randomly allocated to control or intervention, and that'll be repeated throughout the Woreda, throughout the areas. We'll get population consent and also individual consent. And we have 2 study sites. So in Jimma, we hope to have 14 versus 14 health centers randomized, and in Deder Woreda, overseen by GOAL, to have 4 intervention and 4 control areas. So briefly to outline our PICO, and starting off with P, our population is those who are small. So i.e. those who have a birth weight less than 2.5 kilos, or those who are nutritionally at risk. So we'll principally enroll those who have a low weight for age, that's less than -2 Z-score, or those who have a low MUAC. And we've got these 2 different cutoffs depending on their age. So if they're under 6 weeks old, it's less than 110. If they're 6 weeks to 6 months, less than 115. We will also enroll, but we'll not count towards our main sample size, those who have a low weight for length, who have growth faltering, and those who have reported breastfeeding problems. And this enrollment criteria is very much recognizing that there are 3 main time points of risk. So there's risk at birth, there's early life risk, so issues that develop over the first 2 months, and there's also later infancy risk, so that which develops at 2 to 6 months of age, and especially, as Carlos very nicely presented, as breastfeeding starts to go down, as other foods start to come in, and the risk of contamination, diarrheal disease, and growth faltering secondary to that. So small and nutritionally at-risk infants will be our population. Our intervention is a Mammy care pathway, and this is a 2-phase process. So all infants under 6 months, at every healthcare contact, so that's at birth, at neonatal visits, at immunization clinics, at under 5 clinics, so whenever they're presenting for a minor illness, whenever they're presenting for growth monitoring. So they will have a rapid screen, which will consist of weight and weight for length and MUAC assessment, and a few very rapid quick-fire questions. And most infants will be okay from that. So most infants will just be reassured, no further action needed. Based on the formative work, we expect that about 10% or so will be small or otherwise at risk, and they will have a detailed assessment using the MAMI checklist, and that will take place at the nearest health centre by trained staff. And from there, there may be a small number who, at that stage, we can reassure no further action is needed. But from there, most will be allocated either to standard care, which is advice and referral, or to our new MAMI care pathway, and we'll follow both of them up at 12, 18, and 24 months. So our intervention is the MAMI care pathway, and you can see details of this online on our website, but the core things about it are that it's a very simple, scalable checklist, and it's based on IMCI, the Integrated Management of Childhood Illness, which is well tried, well tested over 20 years or so, so people are used to it. It's going to be administered by clinic nurses. And how it works is it's a simple checklist. So we look for danger signs, we look for relevant signs, and the checklist takes us through that. And what it helps us do is identify the main problem. So in some infants, it might be a simple breastfeeding issue. In others, it might be underlying illness or disability. In others, it might be maternal illness or maternal mental health. And in some, it may be a combination of these. So the checklist helps us identify what the problem is. And then we provide responsive support tailored at addressing that problem. And the key thing is that it's a behavioral intervention. So it involves breastfeeding support. So general breastfeeding support, there might be some specific things, for example, treating mastitis or attachment problems. We're exploring some work about maternal relaxation as a well-demonstrated thing to improve milk supply and to improve infant growth. And they'll be addressing other issues as identified. And again, it's using the guide to help target what the underlying problem is in a particular mother-infant pair. And then if there are other interventions needed, other problems, those will be referred. So the Mammy care pathway is a bit like a signpost. So it treats some problems there and then, but what it also does is signpost infants and mothers to relevant support and interventions. It involves phased intensity outpatient visits. So there's a step down if the infant is growing and improving. So initially we anticipate weekly visits, so approximately 4 weekly visits. And then if things are going well, then we'll step down to fortnightly and then monthly visits. So that might be a maximum of 4 if the infant is enrolled early on. And on the flip side, so if things aren't going well, then there'll be a step up, so more intense visits or referral to inpatient care to other clinical services if needed. At each visit, there'll be an anthropometric assessment where we figure out, is the infant growing well? There'll be a clinical review. How are they doing clinically? We look for any other concerns that the mother may have or the family may have. And we've also got a topic list of particular things that we want to discuss and reinforce. So messages about feeding, messages about sleeping, messages about development. So the kind of things that Mubarak very nicely outlined. So really trying to integrate other services, other pathways into the Mammy visit. And then the main outcome is at 6 months of age. And at that point, there'll be a number of options. So the main option will be, and we hope that the majority of our children, especially in the intervention areas, will be growing well. And in that case, they'll be discharged with no need for specific further care. There may be, however, some who are still small, still vulnerable, and especially those who are wasted at age 6 months. And they'll be referred to CMAM services, or if they have clinical problems, will be referred to other clinical services. And if there's default, if we don't know what's happened, then we'll be proactively following up in the community to find out. Our outcomes we measured at 6 months of age, 12, 18, and 24. But our main time point is 6 months. And so we'll be doing a major analysis and write-up at the 6-month outcomes. And again, we've got very generous funding to help us follow up for a longer time period to try and figure out the longer term impact and benefit. Our primary outcome is weight for age Z-score, so a change in the mean weight for age. And then we've got infant-specific secondary outcomes. So that's a change in the other anthropometric indicators, so a change in the mean value, but also are we having a lesser percentage, for example, eligible for CMAM enrollment at 6 months. In a subset, we'll be examining body composition changes. Breastfeeding indicators are again key, so especially focusing on duration. And then we're also looking at illness episodes, key behaviors, especially sleep, which we know is strongly associated with interruption of breastfeeding and early complementary feeding. Development is really key. And again, we'll be examining that at each time point, but particularly at 24 months. And also looking at lab biomarkers of NCD. On the maternal side, we're looking specifically at maternal mental health and perception of maternal social support using standardized tools, because it's, again, really important to support the mother and to enable her to get the best chance to the infant. And the other secondary outcomes are the economic and process indicators. Control will be standard care. So as per current MOH guidelines, those who have a low weight for length, less than -3, will be referred to inpatient care, and they'll get transport money to get to hospital. They'll also get basic nutrition and feeding advice and referral for other problems as needed. Those who are small, according to other criteria, will all get basic nutrition and feeding advice and referral for other problems as needed. And in exactly the same way as the intervention group, all infants will have a full review visit at 6 months of age, and then also at 12, 18, and 24 months, and of course, an open door to any other problems in the meantime. So that's it for our basic plan. So very quick run through and open to questions. And again, really value your opinion. So we haven't got an animated version of this, but the big theme on Mammy is building bridges between different sectors, bridging, for example, nutrition and health interventions, bridging the community and healthcare facilities, bridging the gaps between a focus on the infant and a focus on the mother in society, and bridging gaps between developmental programs and humanitarian programs. And it's about GRIP, getting research into policy and practice, and very much appreciate and looking forward to your comments, questions, and suggestions to help us with that. So thank you very much. Over.
Thank you so much, Marco, for your nice and brief presentation. So now it is time for discussion. We will have 30 minutes to receive feedback, comment, and questions from everyone. That will be very helpful and supportive to our future work. So I will have the privilege to mute you everyone, and I will give chance for those who would like to comment on the overall presentation. Since the start of our meeting, we have introductory presentation by Mari. We have the qualitative finding presentation by Naga. We have the anthropometric deficit prevalence presentation by Carlos. And we do have a nice overview of DHS data from Ethiopia by Visu, and some presentation related to research and policy by myself. And now lastly, we do have a good introduction on the upcoming RCT research work by Marco. So everyone who are interested to share your opinion, your feedback, especially on the opportunity we have to implement this project and the threats that can hinder effective implementation of this research project. All ideas, opinions, and feedbacks are very welcome. So can you show me your hand so that I can put the list and put under the order for feedback? Can you raise your hand? Can you show me your hand, everyone who would like to share your experience?
Perhaps some of the people who have, sorry, Mubarak, go ahead.
Please, welcome, Carlos.
No, I was just going to say that there are questions in the chat that people might want just to comment on them or to kind of initiate a discussion. So please feel free. I am monitoring the chat, but I know that Alice and many others made questions. So I mean, this might be a good time to have an open discussion about the things that you would like to talk about. Over.
Yeah, sure.
Perhaps we can also start with what everyone might see as potential opportunities you see through this research from where you sit.
Because I think just building on that, so one of our themes in MAMI is to try and build bridges, connections. So for those of you who are from different organizations, I think really interested to hear how this may benefit, support your work, either in the short term, but especially thinking long term. Maybe it's all just to kick off. You know, one thing that we've been wondering, and that many people ask, is about the importance of maternal focused intervention. So I'm just chatting to Lawrence at the break, and Jessica also from WFP viewpoint. We're wondering about, you know, how common is supplementary feeding for mothers, and is that at all is that targeted at all breastfeeding mothers, or only for those who say have a low MUAC, who have signs of anthropometric deficit, who may be malnourished? So yeah, very interested to hear, you know, from yourselves or anybody else who knows the context for feeding mothers in Ethiopia. Over.
Yes, if I may, very briefly, the program I'm working on, we don't actually conduct screening. We just, since the blanket general food distribution program, we, after targeting the beneficiaries, we assume that the lactating mothers or the pregnant women are more vulnerable than the others. So we tend to prioritize them over the other beneficiaries, and serve them ahead of the other registered participants of the program. We missed the opportunity to get to study and understand them, and that's why we are looking to being more intentional going forward in the next iteration of our program to work with the health facilities in the communities to conduct some screening, conduct some MUAC screening, and follow up with the mothers and the children going forward. So this is a learning process for us as well. Thank you.
Thank you. And so in Ethiopia, how widespread would then supplementary feeding be for pregnant and lactating mothers? You know, would that be throughout Ethiopia for everybody, or only in, you know, food insecure regions? How is it spread? And in particular, is there any in Deder or Jimma? Over.
Marco, if I may comment on this. Yeah, I think supplementary feeding for pregnant women or lactating women is not given universally. It's given as a program. There used to be what we call program, which has been conducted by local communities to screen under 5 children for wasting, as well as also pregnant and lactating women. That means lactating women or women with babies less than 6 months old. So if they fulfill the entry criteria, they will be enrolled for supplementary feeding. They will be given CSB oil, edible oil for 3 months ration. And that is what we have as a feeding program for vulnerable mothers and vulnerable pregnant women and lactating women. Otherwise, we don't have a standardized large-scale program which targets across the country. And these programs are implemented in areas where there is historically food insecurity. For example, in Jimma, we don't have this program. It used to be called Targeted Supplementary Feeding Program, and was supported heavily by WFP. The supplements are being delivered by WFP, while the screening is being done by local health workers like health extension workers. So it's based on certain criteria, as well as the geographic locations are identified based on historical data on food insecurity. So just to add to the discussion. Thank you.
Great, thank you.
Can I add a question? Sorry, and there is also some questions coming up from the chat. And I'm just wondering if this is something that our colleagues in Jimma, thinking Malcolm Mubarak could also address. Our colleague Basundra is asking whether we have any strategy that we're adopting for the RCT in lieu of COVID-19. So maybe this is also an opportunity for us to talk a bit of this. And my second question, this is a personal one. I mean, I show some of the data with the introduction of the different liquids, water appearing to be the most common liquid being introduced during the period that you would expect exclusively breastfeeding. And Nega has done very interesting work trying to address why people might be introducing liquids. But I mean, a lot of people in this chat have a lot of experience with regards to infant feeding. And I just wonder, kind of like on the other way of the question, on the inverse of the question, do you know what prevents mother, or what mother think or know or understand that prevents her from giving water to the children? Because we kind of understand why they give it, but I don't know if we have clarity as to why they would not give it, because maybe that is what we need to focus on. Over.
Probably to respond to some of this. I mean, with regard to the Vasu's question, with regard to the COVID-19, we are just planning to implement the updated WHO as well as Ethiopian Ministry of Health's national guidelines to prevent the spread of COVID-19. When we are going to implement the data collection and follow-up of these infants enrolled into the RCT. So we are making our schedules or our activities in line with these recommendations. That's what we have been also doing when we're carrying out qualitative and the quantitative studies. That's one. Probably with regard to the second question that Carlos forwarded, I think when we carry out the qualitative study, some mothers have given us important clues as to why they don't give water. While there are mothers who feel the breast milk is not enough to fulfill the water requirement of the infant, which is leading them to start water early, there are mothers who also think the reverse. That means there are mothers who think or who know that the breast milk has enough water so that they don't provide an additional water or any other liquid to fulfill the requirement of the water requirement of the infant. So this is also what I personally experience during my clinical activities. So some mothers also know that the water content of the breast milk is enough to fulfill the requirement of the infant. That's why they don't give the additional water in addition to the breast milk.
Thank you, Malcolm. Maybe Naga, do you have any compliments that you come across these issues in the qualitative study?
Okay, just to add a few points with what Malcolm has already mentioned. In fact, mothers have better awareness about why they don't give solid food items for their infants than water. With solid infants, they are aware that the stomach of the infant does not digest that. That is what the usual answer they give us. But with regard to water, some of them, as Malcolm already mentioned, are aware that breast milk is enough. So not important to give or not necessary to give water. But most of them responded to our questions that health extension workers told them or even ordered them not to do that. So that is the peak of their understanding for most of the mothers. They are just ordered by health extension workers to avoid giving water.
Thank you.
Just to reflect on this as well, Mubarak, if I may.
Please, you're welcome.
I think it's very interesting to hear what Naga said at the end. It's good to hear that the health information that's being given by health extension workers is being adhered to. Mothers are listening to the advice by health extension workers and are avoiding the prelactal feeds. But what's also a bit worrying is they don't know the reason why they are doing that. So they just do it, but do not know why they do it. So I think maybe this is something we can work on, or at least communicate with the respective professionals. So mothers should know why they are not supposed to give. It's good that they are not giving it, but doing it with a reason is also better, because they can also inform neighbors. They will be able to influence their families, their neighbors better than just saying it's just because the health extension worker said it. While I'm saying that, I think I was also surprised to not to see as one of the things that are being given as prelactal feed or during the first few weeks is herbal medications or sort of herbs. That is very common, especially in rural places. They think babies, they are exposed to illnesses, so they may benefit from getting some herbs. So usually parents mix water with herbs, not for just for the sake of giving them water, but also to deliver some herbs. They introduce water. So as a medicinal value. Of course, probably, I don't know, maybe this was not like a quantitative study, but there could be also a possibility of looking at if some of these mothers were facing challenge during the first few weeks, in terms of breastfeeding. So when parents face challenge, they are forced to revert to some other options. Either they have difficulty in breastfeeding, or they feel they are not producing enough, or they might have some other conditions that prohibits them to give optimal breastfeeding. So in that case, they revert to giving some additional materials like water and diluted milk and so on. So this is also being, that's what I observed from my clinical practice as well as also from previous studies on prelactal feeds. Thank you.
That's very interesting.
Just to add a few points what on Professor has already mentioned. By the way, the community entirely is in dilemma with not giving water to infants, because it is highly strongly associated with survival. Even there is idea that how life can survive without water. So there is a clue that most of mothers, including those of educated one and including the workers, give water for their infants from the early days of the infant after birth. So there is a strong dilemma with that, and it is sometimes even considered as immoral not to give water to infants. Thank you very much.
Thank you, Naga. Thank you all for responding and clarifying issues. Now, can I divert you toward this discussing what could be the potential barriers or obstacles and challenges toward this implementation of this research project here in Ethiopia, Jimma and Deder in Harar, especially as we are implementing this research project in the context of COVID, and also by enrolling mothers and young infants together into the intervention arm. What could be the potential challenge and barriers and obstacles for successful implementation and completion of this research work? You can share us your concern, experience, and based on your work in other countries or here in Ethiopia. Any concern is very welcome.
Thank you, Mubarak. And maybe just to elaborate on what you're saying, I think one of the plans, as Marco outlined, is to follow up infants at age 6 months and 18 and 24 months. And it'd be interesting to see if you think there are any barriers or experiences that you have in securing that longer term follow-up, and particularly where infants may not be considered sick or unwell by mothers and families, and how they might prioritize or not taking a child for follow-up, which is quite critical for us to have longer term follow-up on these infants. So again, any experiences and challenges you might see in that regard?
Yeah. So the floor is open for anyone to share your experience.
I'm coming again, Mubarak. Just
okay, thank you.
I think we can expect still the the usual barriers like community resistance, security, some emergency situations, and so on, to affect the study. But in terms of long-term establishing long-term follow-up, encouraging parents, I think one of the most important things is effective communication with parents, building an effective communication and relationship with families who have got their babies enrolled in the study, and they should see some sort of benefit in being involved in this research. Of course, we're not trying to incentivize them just to be in the study, but at least having a proper follow-up, having a contact with professionals will give them an opportunity to ask questions, get some health advice and so on. So I think that's an important thing we should consider. So from the outset, the team should really focus on creating a proper environment, creating a good relationship with parents. That's what we've seen, for example, in our IABC cohorts. Of course, these are babies born around in Jimma town or living in Jimma town, and probably more educated families. But we managed to keep them in the follow-up for almost more than 10 years. So one of the things was, the parents have already established a very strong relationship and trust with the study team. So if we create that from the outset, I think follow-up could be ensured. Of course, we can mitigate, but not completely avoid dropouts, because people can drop out for various reasons. But that's something we can work on. I mean, others can add. Thank you.
Can I just follow up with a question there, Sinuel? So when you were trying to kind of develop this rapport with each of the people that you were following up, how did you translate this into, for instance, here we're going to be having a lot of community health workers and outpatient health workers. We're going to be dealing with this kind of relationship. What emphasis do we need to do perhaps during the training for all the study staff so that they develop this relationship? What's the emphasis of the focus that need to kind of like occur? I hope I'm clear. Over.
Yes. I think again I refer to this, things that apply anywhere in the world. For to create a good relationship, first there should be mutual understanding. There should be a clear communication, of the purpose of the study, what they can get, what they cannot get clearly. From the outset, people can come with expectations, but I think they have to be clear that this is not something that they will get. For example, if they think that they will get free treatment when their babies are sick, or they get some money for the follow-up and so on, I think that's not the case. But they will be checked, they will be getting advice and so on. So making clear the expectations is one, and being respectful to the local culture, to the giving them a human touch to the communication is also important. Speaking their local language and understanding their situation is really important, and also having a listening mind, or at least being able to listen to parents if they have concerns, if they have questions, is also something that we can capitalize on. also being helpful if they have something that we can address within our capacity, within our mandate. This is something that they appreciate. And so in a more, giving them a dignity, keeping their dignity, very common things to do. We don't need to do something very special to keep them in the study. So these basic principles are really effective in most of the cases.
Thank you very much. That's very clear.
Yeah, just to add a point, we have to also clearly inform the benefit of the research outcome to the larger community in the future. This makes their expectation low at the moment, and they will look forward about the larger benefit to the community at large, just to complement. Yeah. Thank you.
Mubarak. Just a few points. Okay. Probably the caregivers' lack of tolerance should be highly emphasized in this regard, because in the qualitative study, we came to know that mothers escape from hospital, from health center, leaving their admitted infants in the health facilities. So this could be the challenge, the persistent challenge with the follow-up and adherence with regard to mothers, particularly in Deder. This is very serious because mothers cannot leave their trade even for a few days because they totally rely on that. And the other one from the health workers' side, in fact, in our study, we were attempting to understand how they look at MUAC in terms of its suitability, whether it is friendly or not in measuring infants. But as we all know, they totally and quickly shift to its diagnostic power. They have a great fear, reservation, whether it really can identify infants with malnutrition compared to the other established measures. So this has to be also taken into consideration. Thank you.
Thank you, Naga. I think we do have a very nice recap of the challenges and barriers to this implementation of this research project, specifically on the long-term follow-up of the project. I think let me give the chance back to Mari to facilitate the next few minutes.
Thank you, Mubarak, and very interesting. And as we say, we just welcome any questions at any time. So in follow-up to this meeting, we will share some of the contact details. And so really, please don't hesitate to come back to the questions or suggestions. I'm just going to do a quick couple of minutes just to share some opportunities more internationally, and then I'll hand over to Sinuel. The first thing just to mention is that many of you will be aware that the WHO are updating guidelines on management of wasting. So their normative guidance in an update process over the next couple of years, with a view to generating updated guidance by the end of next year, early 2022. And one of the areas of focus is under 6 months of age. And it's been framed as growth failure or growth faltering in this age group. So a scoping review was conducted to feed into the beginning of this process, which ENN, London School of Hygiene, Tropical Medicine, and collaborators from the Mammy Special Interest Group undertook. This fed into a scoping guideline development meeting that happened just last week, where the guideline development group, of which Marco Karak is one of the members, reviewed the scoping evidence, and this is going to lead to a series of systematic reviews and other types of evidence compilation that will be commissioned by WHO over the coming 6 months. So, and then mid next year, most likely, in the second or third quarter of the year, there will be a large guideline development meeting hosted by WHO, which will include infants under 6 months of age. So we are connected in with this process, and it's just to highlight the really great avenue there is for influence and learning at a policy guidance level, and how what's happening in Ethiopia is really very much informing what will be happening, we hope, at global level. And indeed, we will in turn will be taking back what is happening there and sharing it with you. So that's one thing that we wanted to highlight, and we'll be sharing updates on our website as well as that process goes on. And the second thing I just wanted to highlight with you in my opening presentation, I just mentioned that we are looking to update our MAMI vision, both for the MAMI approach and for the MAMI global network. So we have a couple of vision options on the table that we've been working on. So I've just shared the three of them here with you. So the first one, every small and nutritionally at-risk infant under 6 months is supported to survive and thrive and achieves their full potential. And then we've just reframed it in slightly different ways. For example, strong health and community systems support all small at-risk infants to grow, survive and thrive. And the third is a world where small and nutritionally at-risk infants live, grow and develop their full potential. So we'd be very interested to get feedback on these. To get what you think would be a great way of framing the MAMI approach, and what you think makes sense, resonates. And as I say, we're also doing the same for the MAMI Global Network, the collaborative effort, and we'll have a mission statement around that. So we will be putting out a sort of a very brief survey monkey to get feedback. And so we will share it with you who have registered with and really would encourage and welcome your input on us framing our MAMI vision, as this will be fundamental to guiding the steps we take in order to realise this. So that's it from me, and I will now hand over to Sinuel.
Thank you, Mary. So you want me to
perhaps have a few words. I think maybe we had a great opportunity to present on MAMI on the Ethiopian Nutrition Leaders Network about a couple of weeks ago, and perhaps any opportunities you see there, the discussions we were having maybe about developing a MAMI chapter within that network.
Yes, I think this is quite a possibility. You know, one of the reasons we asked you, or we invited you, and then you graciously accepted and did a very quick presentation, preparation and presentation at the Ethiopian Nutrition Leaders Network. It was to sensitize the wider nutrition community about the importance of working around MAMI, and also to sort of inform the current work that's being done at international level and also at local level. And then that is like a springboard to create an opportunity for a more sustainable mechanism locally. So that's where the chapter came in the discussion. I had quite a few meetings with my colleagues in the Nutrition Leaders Network, and they are happy to explore the possibility. But what I see also is we have a very nice group of professionals and experienced and motivated staff from Jimma. So we can think where we can place this chapter and who should be in the lead, like coordinating the activities. So along the way, we need to discuss more and also develop a sort of the clear objective and the scope of activities, for this chapter. My quick understanding or reflection is the objective and the scope should cascade from the international MAMI network, but of course that should be contextualized and then could be tailored to the local needs. Maybe some of the things that we can do is do some advocacy work among policy and program people here, researchers and funders as well, because there are lots of research gaps that are important to be addressed. So having institutions or organizations that can support the research activity is also really important. So I think these are some of the things that can be taken care by the chapter. But in terms of where to put it and what should the actual activity look like? I think we need to discuss more with that. Then we can take this opportunity also to get feedback from other colleagues. I don't think we have discussed this with Malkamu or Mubarak. Maybe it's the first time they are hearing about this. So if they have any quick reflections or thoughts, they can give us. We can also think of embedding this in other existing structures, not only the ANLN, but also if there are other favorable existing structures, maybe we can create synergy instead of creating a standalone structure. You know, maybe it would be helpful to work with other existing platforms for synergy or efficiency and so on, and getting more leverage. So this is my quick reflection on that, on the MAMI chapter. I don't know if this is helpful, Maria.
Yes, it is. Thank you, Sinuela. That's perfect. And I think exactly as you say, we're very keen to make this connection with the global network. And as we're looking at a sort of a scaled up or a new way of working, and having these sort of regional and country specific context hubs, we think is really fundamental for us to understand and figure out how you get evidence into policy and into practice. And indeed for the Ethiopia research as well, looking at what are the practical opportunities there are for policy guidance and influence, and what are the priorities at country level. As Marco highlighted, that we really want to capture the how this works, and the learning that we can capture at that level, as well as the sort of randomized trial element and the sort of actual results of the trial. Malcolm or Mubarak, have you any sort of reflections you'd like to add from what Sinuel outlined?
Just to start with it, I think this is my first time to hear about this nutrition leaders in Ethiopia formally. I just heard about it informally from people talking just around. So I also believe that linking up this our work with nutrition research leaders of Ethiopia is very important, rather than standing alone in the Iceland. So we need to make a formal communication, and also presenting our work to national meetings if organized. And as Sunil said, probably one of us, especially Malkamu, may link up our work with these leaders, so that we can invite them to our upcoming meetings and communications. We can also be invited to an event if they organize and facilitate in the future, so that we can share ideas, experiences, and the way how to scale up finding from this research work, linking with what they are thinking and working to the country. Definitely they will have a separate work, so that we can line up our work with their thought. So it is very important to get to know them well. Thank you.
Yeah, thank you, Marie. I completely agree with what Mubarak has mentioned. We need to use such platforms to get to get connected with other groups working on a similar area, and probably we will use Noel so that he will liaison us with this group, so that we will learn from what they are doing, what others are doing, and we will also share what we are doing with the rest of the group. So probably we will look a way forward how to collaborate with this group. Thank you.
Brilliant. Thank you, Malcolm and Mubarak. I think this ties us in nicely. I think we're in the closing minutes, and thank you so much, everybody, for joining and staying with us. I know people had to leave as well with busy schedules. So I'm just going to hand over to Professor Amsega for some final reflections to close the meeting.
Yeah, thanks, Mari. Thanks, everyone. Great talks and discussions. And we remember this study is supported by Eleanor Kroc Foundation, and we are honored by the presence of Chataya Kampala, who wants to say a few words, probably. Chataya, are you there?
Yes, hi, thank you. I'll just be very brief and very happy to be joining you all today. Apologies for missing the first hour, but it's been wonderful to listen into this really important stakeholder meeting and part of a broader process of engaging with each and every one of you. So huge thanks to the research team, to LSHTM, to Jimma, to ENN, and huge thanks to all of the other stakeholders who've participated. Your input into this project will be really key to the success. So from everyone at the Eleanor Kroc Foundation, many thanks for your efforts on this, and we're here to support you all throughout the journey of Mammy in Ethiopia and beyond.
Many thanks to you, Chaitanya, and everybody at the foundation.
Yeah, thanks, Chaitanya. And we really had just great talks. Started with Maria's presentation about the Mammy at the global context, which is really helpful to catch up with the progress, and also the presence of the special interest group which catalyze change in this area, which is a really important public health problem. And just this Mammy program, to the vision is to allow just to every infant under 6 months in every community to get an opportunity for nutritional assessment. And it's really important to emphasize that this Mammy just is a bridge, serving as a bridge to bring people from different institutions and from different countries, and also from a community to the health institutions and the health workers. And the talk from Nedga was really helpful about the caregivers and health workers perspective. Nedga pointed out about the perspective of caregivers, for example, what it really means for the child, for mothers to see or how they assess the well-being of a child. For example, fatness and attractiveness is really important. That's really important because we need to know the community's perspective to respond appropriately to the need. And it's very interesting to note also about the points he mentioned. Mothers, for example, sell eggs and buy biscuits. What's the reason behind? So it's very important to dig into the social construct about the concept of nutrition, malnutrition, nutrients, and so on, because understanding of the community is important for decision making, just to visit the health institutions, to seek care, and so on. So thank you, Naga, for that. And Carlos, the data you presented, very interesting, and the anthropometric deficient prevalence from the health centers. And the analysis is really important because you presented not only the prevalence of stunting, malnutrition, underweight or wasting, but also the limitation of MOAC to pick this kind of challenge. So it's very interesting, and thank you for that too. And Vasun, the same, the weight for age and weight for length. You rightly mentioned the challenge of the weight for length to identify, and also just the logistic challenge to transport this kind of the length board in the community. Mubarak also highlighted the policy and guidelines supporting the Mammy program, which is very helpful to get an idea about what kind of supporting documents or policies are existing. And then the Marco's presentation about the stakeholder matrix and the material shared from different stakeholders. This shows that the commitment and the from different stakeholders to support each other. So synergy rather than competition is prevailing in this context, which is encouraging. And thank you everyone for contribution to this context. And Marco's presentation about the RST is a nice summary, the design and approach to investigate the MAMI approach, the pathway to address this prevailing public health problem. Thank you, Marco. And then, you know, this virtual meeting platform is working very well. And what we miss is just humanistic relationship among each other. So we had coffee break and coffee chat with few groups. Virtually is very well working. But what we miss is just the interaction, the fun time, dancing, and all the fun. So hope we'll have this kind of opportunity next year. Thank you everyone for the great talk, for the participation, and Eleanor Group Foundation for the support. And get back the forum to Mari to give some housekeeping information. Thank you.
Thank you so much, Seged. A wonderful reflection and close. And just to reiterate, thank you so much, all of you, for joining. And as we say, we have recorded the meeting, so we'll make it available on the website. You can see the link there. And if you've got any other questions or suggestions or feedback, please don't hesitate to contact us. And we've got Malcolm and Carlos's contact details on the screen, and we will share in our follow-up email too. We'd be really grateful if you could complete a small evaluation form so that we can improve how we do these meetings. And so in follow-up, we'll share you a little link. It'll only take a couple of minutes to complete, but that would be just so helpful so we can improve how we do things in the future. And this meeting performance will be repeated tomorrow. The core content will be the same, but we have more of a focus perhaps on the Deder context. So please do share the link to the invite to any colleagues who you think might be interested. And as I say, the recording will be available as well. So thank you all, and have a good morning, afternoon, or evening, wherever you are. Thank you so much for those of you who managed to stay to the very end, and to all the research team who have collaborated together. And we very much look forward to many more of these meetings, and we hope in person.
Great, thank you. Thank you all from me as well. Bye-bye.